to the Methadone Education Program. This talk is about opioid substitution therapy, focusing on special considerations for adolescents and young patients. I'm Cassandra Huck. I'm a pharmacist currently working for Canadian Addiction Treatment Centres. After completing my pharmacy degree at the University of Toronto, I completed a pharmacy residency at the Centre for Addiction and Mental Health, and have since been working as a community pharmacist specializing in the treatment of substance use disorders. I have no conflict of interest to disclose. I will begin with an overview of what we are going to focus on today. With respect to this population, we will look at treatment options for opioid dependence, the CPSO guidelines, and a literature review of opioid dependence in this population. We will review special issues of note with this age group and approaches that may be helpful to take. We will finish the presentation by looking at a case example. Specific data on opioid use in adolescents has been gathered in Ontario through the Ontario Student Drug Use and Health Survey. It has been conducted every 2 years since 1977 by the Centre for Addiction and Mental Health. The survey is administered to students in grades 7 through 12. A total of 11,000 students participated in the 2017 survey. The most recent data shows that over the last decade, there's been a significant decrease in the non-medicinal use of prescription opioids, down from 20.6% in 2007 to 10.6% in 2017. This was in response to the question, in the last year, have you used prescription painkillers or prescription opioids for reasons other than prescribed, such as for recreational reasons or to get high? Opioid dependence treatment used to be primarily for the treatment of heroin dependence. As you can see from the data here, heroin use has always been quite low in this population. Reported heroin use from the 2017 data was less than 0.5%, an all-time low since the survey was started in 1977. Although there has been a steady decrease in opioid use over time, 10.6% represents approximately 97,000 students in Ontario, a significant number. Opioids were found to be the second most commonly used illicit substance by this age group, with cannabis as number 1. Only 7% of students in the survey reported past year use of tobacco cigarettes, meaning this group were significantly more likely to have used an opiate non-medically in the last year than to have tried smoking cigarettes. Males and females were equally likely to use opioids non-medically. The majority, 55%, of past year users reported obtaining these drugs from a parent or sibling. The 2017 survey showed a slight increase in the perceived availability of prescription opioids. When participants were asked how easy they felt it would be to obtain prescription opioids without a prescription, 22% indicated fairly or very easy, up from 18% in 2015. A new question was added to the survey in 2017 about fentanyl use, given the recent increase of use in the general population. Approximately 1% of students in grades 9 to 12 reported past year use. While this might seem low, it indicates that approximately 5,800 Ontario high school students have tried fentanyl in the past year. As noted earlier, the majority of students who completed the Ontario Student Drug Use and Health Survey reported obtaining opioids from home. Only 6% of students reported obtaining them from friends, a smaller number than might be expected. The fact that the majority of opioids used non-medically are obtained from home highlights the importance of pharmacy education to those prescribed opioids regarding the safe storage and disposal of them. Pharmacists can play an important role in ensuring reasonable quantities are dispensed at a time and in working with patients to ensure unused narcotics are returned to the pharmacy for safe disposal in a timely manner. Many individuals may feel that their adolescent family member would never try an opioid. Sharing the results of this study and explaining to patients that even if they feel the risk is very low, the safe storage of prescription opioids, such as using a locked drawer or cabinet, can help ensure the safety of our youth. More specific to urban areas, the Toronto Drug Use Survey of 2010 provides information on rates of use of prescription opioids among some urban marginalized populations. An organization called TRIP provides harm reduction services to the dance and club community of Toronto. Data they gathered from this population showed that almost 3/4 of youth attending dance clubs reported non-medical use of prescription opioids. Rates equally as high as this were reported by homeless and street youth. In this population, half of homeless female youth reported use of fentanyl. High rates of heroin use have also been reported. This population has a much higher rate of transition from oral or intranasal use to intravenous use of opioids. This translates to higher rates of infectious disease, such as hepatitis or HIV, higher rates of drug overdose, and has been associated with higher rates of suicide. The same as with the general population, there are two main treatment approaches that can be taken with youth and adolescents using opioids: abstinence-based approaches or opioid substitution therapy. An abstinence-based approach may be best for those who've been using for shorter periods of time or who binge use once in a while, such as on weekends, but who may not necessarily be dependent on opioids. Abstinence-based treatment options may include an opioid taper, gradually reducing the amount of opioid they use. This is best done if they are prescribed opioids for chronic pain conditions or if the individual is under highly monitored conditions, such as during an admission to a hospital or a medical detox center. The taper is ideally done with a different opioid than the one they are dependent on. For individuals wanting to stop opioids abruptly or by taper, we can offer symptomatic treatment of opioid withdrawal symptoms, which is described in more detail on the following slide. Following abrupt cessation or completion of an opioid taper, follow-up therapy may be naltrexone-based. Naltrexone is a mu receptor antagonist which can be used to deter opioid use if taken regularly. Individuals must be highly motivated to adhere to an abstinence-based approach. A highly structured environment helps ensure the individual is taking the naltrexone on a daily basis. It's important to be aware of the high risks associated with relapse in patients who take an abstinence-based approach to therapy. Overdose rates are high in individuals who relapse, as there is a loss of tolerance when opioids are stopped for a period of time. For this reason, the Canadian Guidelines for Managing Opioid Use Disorders, published in the Canadian Medical Association Journal, recommend avoiding withdrawal management as an isolated strategy due to the high rates of overdose. Younger patients are more likely to meet the criteria for abstinence-based approaches, as periods of use tend to be shorter, and they may be more likely to have a support system in place to encourage adherence to an abstinence-based approach. For example, if they still live with their parents and have them supporting and monitoring progress. Opioid substitution therapy may be considered as a treatment option for youth who have a longer duration of opioid use and who meet the criteria for an opioid use disorder. In Canada, the main treatment options are buprenorphine or methadone. Slow-release oral morphine may be considered in patients for whom these options are ineffective or contraindicated, although its use for this indication is off-label. In patients who have stopped or are tapering off of opioids, withdrawal symptoms are very common. There are several medications we can offer them to help minimize these withdrawal symptoms and discomfort. As these patients are likely to experience agitation and anxiety, sleep can be difficult. Sleep aids, such as trazodone, may be helpful in managing this short term. Clonidine can help with agitation related to opioid withdrawal and also helps to treat sweating that may occur. Antiemetics, such as dimenhydrinate, and antidiarrheals, such as loperamide, can help with the GI symptoms of withdrawal. Over-the-counter pain medications, such as acetaminophen or NSAIDs, can help with the body aches and pains individuals may experience. In cases where extreme anxiety and psychological distress are noted, physicians may prescribe sedatives such as diazepam or another benzodiazepine to treat. Due to their potential for abuse, these may be prescribed as daily observed doses at a pharmacy or from a reliable family member for a short period of time, usually about 7 to 10 days. For the majority of patients with long-term dependence on opioids, maintenance therapy is the preferred treatment approach due to the high risk of relapse following detoxification. Maintenance therapy is generally a long-term approach, which tends to have better success rates. For some individuals in the youth and adolescent population, detox may be a consideration. There is no clear amount of time recommended for detoxification. Some complete it very quickly in a matter of days, while others may detox over months. This is very dependent on the individual patient. For patients in whom opioid substitution therapy is the treatment approach of choice, consideration must be given to whether methadone or buprenorphine is the most appropriate treatment. Buprenorphine, dispensed in Canada in combination with naloxone, also known by the brand name of Suboxone, is generally the first-line treatment option to initiate with these individuals. Patients in the youth population seeking opioid substitution therapy tend to have shorter durations of use, may not be fully dependent on opioids if they have binge using patterns, and tend to have a better prognosis than individuals from older age groups seeking treatment. Buprenorphine may be a better option for individuals concerned about the stigma that is commonly associated with methadone use, or for those who may not have access to methadone, such as individuals from rural communities without a methadone prescriber, or where daily ingestion at a pharmacy may not be feasible due to distance, as Suboxone offers more flexibility with dosing. Physicians do not require a Health Canada exemption to prescribe buprenorphine the same way they do with methadone. Therefore, it is much more accessible for patients. Compared to methadone, buprenorphine is associated with a lower risk of toxicity, morbidity, and death due to its partial agonist properties and ceiling effect for respiratory depression. As this age group has high rates of use of other sedating substances such as alcohol, it is important to counsel them on the increased risk of overdose if buprenorphine is used in combination with alcohol or other sedatives. Another reason buprenorphine is generally first line is that it's easier to transition from buprenorphine to methadone if treatment is unsuccessful, much easier than it is to transition from methadone to buprenorphine. Overall, buprenorphine is a better option for individuals with lower intensity opioid dependence such as oral use only, a shorter history of use, or those planning to taper off in a relatively short period of time. It should be noted, Suboxone is actually only approved by Health Canada for individuals over the age of 18 years. In other jurisdictions, it is often used in younger age groups. In Australia and the United States, there is approval for use in ages as young as 16, and in parts of Europe as young as 14. With respect to methadone as a choice for opioid substitution therapy, the College of Physicians and Surgeons of Ontario recommends prescribers adhere to the following guidelines. Consider abstinence-based treatment or opioid substitution for withdrawal purposes for patients under 18 years of age with a shorter duration of opioid dependence. Consider methadone maintenance treatment only after thorough assessment and discussion of all treatment options, including buprenorphine treatment. Ensure there has been discussion about potential issues with methadone, including side effects, risks associated with treatment, and difficulty tapering off of methadone. The provider is encouraged to seek and document consultation with another methadone provider prior to initiating a patient under 18 years of age on methadone maintenance treatment. Although there are stricter guidelines for the prescribing of methadone compared to buprenorphine in this age group, methadone may still be a treatment option of choice for some youth and adolescents. It may be associated with better treatment retention in individuals with higher intensity opioid use, such as those with a longer history of use, intravenous use, or high tolerance and frequency of use. It is generally regarded as the second-line therapy of choice for patients in this age group in whom opioid substitution therapy is indicated. A literature review of methadone use in adolescents and young adults shows that data for methadone use in this age group is quite sparse. Observations from the literature that does exist show that this population can be chaotic and sporadic with their entry into treatment and compliance with treatment in clinic and pharmacy settings. The longer they are on treatment, the more likely they are to have positive outcomes. Data also indicates that these patients have many other factors in their lives that need to be addressed in addition to opioid use. This includes the use of other substances, as well as the impact of substance use on their family and friends, their school, and their work endeavors. More holistic approaches to care make for better treatment outcomes with this population, as with older age groups. Special issues that exist for this population, which we will discuss in more detail in the following slides, include physiologic dependence versus addiction, the issue of polysubstance use, comorbidities, including mental health and medical disorders, effects of opioids, including those used for treatment, on the neurodevelopment of an adolescent, and the topic of consent. The spectrum of physiological dependence versus addiction is greater in this population due to shorter histories of use. Younger patients are more likely to be physiological dependent on an opiate, but may not necessarily meet the criteria for addiction or an opioid use disorder. Most will report experiencing withdrawal symptoms upon cessation of opioids, as well as the development of tolerance. However, they may not necessarily report use despite harm or a negative impact on family, school, or work obligations. Younger patients are less likely to have progressed to intravenous use, which is associated with a greater level of dependence. Many use only orally or intranasally. Assessing whether or not the patient is seeking treatment due to physiological dependence alone or due to the development of addiction can help guide therapy. Polysubstance use is very common in this population. Although all age groups report higher rates of alcohol use compared to other substances, the pattern of use in this age group is significant. Many younger adults binge drink alcohol, primarily on weekends or special occasions. When they use, they tend to drink a lot. This is associated with sedation and impaired decision-making. For individuals on substitution therapy or who are still using illicit opiates, this can lead to very serious outcomes. This population also has high rates of cannabis use. The Ontario Student Drug Use and Health Survey 2017 data showed that 19% of these individuals used cannabis in the last year. This is another consideration to take when serving this population. Sedating over-the-counter medications, such as cough and cold medications containing dextromethorphan, are used more commonly by this age group, as it may be all they have access to. 9.2% of survey respondents in 2017 reported using these products in the last year. Other OTCs that may be misused include dimenhydrinate and sedating antihistamines. Ketamine, GHB, or other sedating substances may also be misused. It is important we inform patients on opioid substitution therapy of the increased risk of overdose associated with polysubstance use. Compared to other age groups, young adults report the highest rates of co-occurring substance use and psychiatric disorders. This may in part be due to several stressors unique to this age group, such as the initiation of independent living or moving away from home, and educational transitions, which can include stress associated with starting post-secondary school. Over 80% of young adults seeking treatment for substance use disorder report mental health symptoms. Many of these patients have not officially been diagnosed or treated for their mental health symptoms at time of presentation. For substance use disorder treatment to be effective, it is important these patients receive treatment for other mental health disorders, such as depression or anxiety as well. Many in this population struggle with learning or behavioral disorders, including attention deficit disorder. Frustration associated with these disorders and the related lack of success in school and social relationships may be what led individuals to substance use in the first place. Some patients may present with drug use-related medical illness, such as hepatitis C or chronic liver disease, although less common in the younger population. This group may have issues related to binge use, such as physical trauma or head injury. Some may have pre-existing medical conditions, such as diabetes or epilepsy. Conditions that can be associated with loss of consciousness or sedation must be taken into consideration when starting opioid substitution therapy. Marginalized youth on the street or who are homeless may have other parameters associated with sedation or high-risk behaviors and issues that make it difficult for them to comply with therapy. Sleep deprivation, nutritional deprivation, and cognitive impairment are factors which may impact their treatment outcomes. A number of studies suggest that the adolescent brain may be particularly vulnerable to the adverse consequences of substance use. In adolescence, an imbalance in the growth of the brain may lead to a lack of cognitive control. It is believed that the protracted development of the prefrontal cortex, which is in charge of executive decision-making, may be largely responsible for the heightened risk of substance use in this age group. Prefrontal cortex development is thought to lag behind the development of more primitive areas of the brain, like the limbic system. This may be associated with an increase in risk-taking behavior. During early adolescence, there is more peer engagement and separating from their parents. During this period, adolescents are learning who they are as individuals. Later in adolescence, there's more of a focus on future aspirations and on further developing their individualization. Prolonged use of substances can lead to negative neurodevelopment outcomes. Permanent changes to many centers of the brain, including the limbic system and hippocampus, can occur with prolonged use. The earlier we intervene, the better. It is very important that as pharmacy professionals, we provide education to anyone we feel may be at risk due to the long-term effects of substance use in this age group. A particular opportunity may exist when there are younger patients purchasing over-the-counter products with the potential for abuse at our pharmacies. With this age group, we may see impulsivity, emotional lability, and distraction. Some may have limited task recognition and problem-solving skills. Because of these factors, the adolescent patient may require more time and resources to ensure effective communication. It is very important with this age group, as with others, that we display a non-judgmental approach and welcome any questions or concerns that they have. A topic of specific consideration with this age group is that of consent. In Canada, the Healthcare Consent Act suggests that there is no specific age of consent. A patient of any age may consent to treatment as long as they are considered to have the ability to understand and appreciate the consequences of the treatment decision. With the patient's permission, we may involve parents or guardians in their care decisions. However, it is not necessary to receive their consent to initiate treatment. So what might we see at our pharmacy? We may see the adolescent behaviors we have talked about, as well as the behaviors of comorbidity, such as those of other mental health conditions. We may observe behaviors that are related to the use of other substances. For example, as discussed, cannabis use is high in this age group. We may need to discuss the use of these substances with patients if refusing to provide a dose of methadone or Suboxone due to suspected intoxication. These patients may be impatient when waiting for their dose of medication. Perhaps they have a ride waiting outside as they do not have a license, or perhaps they are anxious to get to a friend's. There are many adolescents who are highly cooperative and patient, but it's important to remember they may be fairly new at interfacing with the healthcare system and may not be aware of realistic wait times or program requirements. It may be difficult for them to adapt to daily interactions with pharmacy staff or other customers. Factors that contribute to a youth-friendly environment include accessibility, making sure the individual is greeted, let them know how long the wait time will be so that they are not waiting and left to grow anxious. A non-judgmental environment. In most cases, these patients have experienced a tremendous amount of judgment towards them from society and family members. Treatment success and retention is greatly reduced if the patients feel judged by staff at their pharmacy or clinic. We should be there to encourage them, as by showing up, they have made a positive decision to seek treatment. It's important that as professionals, we display not only to patients, but also to our staff that we are not there to judge. Structure and flexibility. Patients must come during the specific hours and do require that structure. But we must be flexible in understanding that these patients may come at different times of day or may not be able to make it in every day. We must be flexible in understanding the different neurodevelopmental stages of our patients and adapt to the different approaches they are receptive to. Confidentiality. This is extremely important for all age groups, but adolescents may be especially sensitive to this. If they are concerned about being seen in the pharmacy, I will offer them the option to wait in our private counseling area. When I see they may be uncomfortable discussing something, I will reassure them that everything discussed at the pharmacy is confidential. I have found with this age group, compared to older groups, that they are more sensitive to topics which we may encounter very commonly as healthcare professionals. Constipation, for example, is a topic that I find older patients are very comfortable talking about in the open, whereas younger patients find this a very private topic and would prefer to speak about it in a private area. It's important to keep these types of things in mind with the younger population. Developing rapport and a good relationship with these patients will encourage them to open up over time and come to us with any treatment concerns. A study carried out in the United States in 2009 interviewed patients, staff, and parents to identify the factors required for successful treatment outcomes in youth seeking methadone maintenance therapy. Both pharmacologic and behavioral approaches were found to be required when treating these patients. Supports for issues related to mental health, housing, school or work, and other substances will help the patient to do well. While these supports will not be carried out in the pharmacy setting, it's important to be aware that all of these factors must be addressed for the best treatment outcome. A long-term commitment from staff is a positive contributor. This allows the patient to build rapport with their healthcare team and allows each professional to become familiar with the specific patient's background. Many youth benefit from individual attention from staff with the assurance of confidentiality. This leads to better retention of patients in treatment. If patients do drop out of treatment, they're more likely to return if they have a good relationship with the staff. The involvement of family members can also make a difference to their outcomes. Taking a flexible approach to care allows us to adapt as professionals to the range of individuals' needs we may encounter. Depending on location, rural versus urban, different resources may be available. We may see students, youth from various unstable backgrounds, including from the foster care system or the justice system. First Nation youth are very significantly affected by opiate use in Northern Ontario. Rural and urban youth may have differing issues. Many rural locations do not have treatment programs in place that offer opioid substitution therapy. Without a car, patients may attend the pharmacy sporadically or may drop out of treatment completely. LGBTQ or marginalized or homeless youth may have issues that are specific to them. IV drug using youth may require our assistance ensuring harm reduction strategies such as clean needles are available and provided to them without judgment. We must be flexible with patients who are seeking harm reduction and not abstinence as their goal at the time. Adopting motivational interviewing techniques can help us to elicit information from our patients on their current beliefs and goals. It can also help us to promote change talk and help them to understand their own inner motivations for change. We must be flexible in meeting our patients where they are at and support them by providing additional information or resources when requested. Part of the harm reduction approach is to understand that substance use disorder is a chronic and relapsing condition. To prepare for relapses and minimize patient harm and risk, we can promote harm reduction strategies, such as having an naloxone kit and training available. After a relapse, when our patients may be feeling discouraged, we can work with them to help identify what triggers may have led to the relapse. We can display to them that we are not there to judge, and this can help build the staff-patient relationship. By supporting them through a relapse, they know that we are there for them when they're ready to re-engage in treatment. I have included a real example here of a patient I recently encountered at my pharmacy. It was a 17-year-old patient who had been using opioids non-medically for a couple of years and had gradually escalated to the point where he was smoking fentanyl almost every day. He had a recent overdose, which led to him seeking treatment. He presented to the pharmacy with his mother for a Suboxone induction. When I was completing the COWS assessment with the patient, explained that he would have to return 1 hour later for another assessment and additional 4 milligram dose, his mother noted he probably wouldn't be back until tomorrow as they wanted to keep his dose low since he plans to taper off soon. What would you like to discuss with this patient? Would you involve the patient's parent? Is there anything you would communicate to the prescriber? In this particular situation, I asked the patient if he would mind if I shared some information in the counseling room. I asked if he would be comfortable if his mother joined us, and he said that he was fine with that. During our discussion, I discovered that the patient had been to a detox facility to stop using cold turkey in the past, and that he had relapsed shortly after. I felt it was important to sit down with both the patient and his mother to explain the benefits of remaining on opioid substitution therapy over a longer period of time and the high risk of relapse if treatment is tapered too quickly. I was glad that the patient consented to his mother being present while I explained this, as I realized through discussion with them that the mother believed that the sooner he was off of opioids completely, the better. She did not see how naloxone differed from other opioids. I was able to take the time and explain this to both her and the patient, and to let them know that the treatment goals should be discussed in more detail with the prescriber. As this patient has been using opioids for a couple of years and was using fentanyl almost daily at the point that I saw him, I felt he would be at a very high risk of overdosing again if treatment was stopped too quickly. After the patient and his mother left, I communicated the information I had learned to the physician. He was not aware of the patient's plan to taper quickly and did not feel it would be the best approach. He was appreciative of me sharing this information with him, and the physician was able to follow up with the patient 2 days later to ensure realistic treatment expectations were set. This case demonstrates a few points specific to youth. It is more likely with younger patients that it may be their first time seeking help for their substance use disorder when you encounter them. More information and a more thorough history of use, goals of therapy, and expectations for treatment must be reviewed. With this population in particular, it's important to involve their family members if possible and if their consent is provided for that, as they may experience pressure to taper off quickly or stigma associated with treatment options if family members do not have accurate information. Each patient you encounter will require different information and a unique approach. Listed here are some helpful resources for patients and family members, as well as reference to several guidelines I referred to during this presentation. Thank you.